I'm going to talk about the role of hip arthroscopy for the dysplasias. There is a disclosure. The background. The patient with hip dysplasia are recognized to have a predisposition toward acetabuloplasty tears, cartilage damage, and progressive osteoarthritis. There is a high prevalence of acetabuloplasty tears, up to 87% of the symptomatic dysplasia patient. The hip arthroscopy was contraindication in the past. There are several studies looking at the favorable clinical outcome after hip arthroscopy in the dysplasias. However, last decade, there are several studies looking at poor clinical outcome for the hip arthroscopy in the dysplasias. So they demonstrated the possibility of a worsened clinical outcome in the high operation rate and progressive osteoarthritis. So we realized isolated hip arthroscopy for the labral region is the presence of underlying hip dysplasias, carrying on higher risk of the clinical failure. But hip arthroscopy is usually beneficial treatment for the FAI, but in contrast, for the moderate and severe dysplasias, the PAO and RAO is an indication for those patients. However, the patient with borderline dysplasias fall into gray zone between the hip arthroscopy and PAO and conventional osteotomy surgery. The question is, when we perform the hip arthroscopy for the dysplasias, what is the proper indication? What are predictors of worsened clinical outcome of following hip arthroscopy? So we investigated predictor of poor clinical outcome following hip arthroscopy for the dysplasias. This is actually what I'm going to present at the next academy meetings. The purpose of this study was to analyze early clinical outcome following hip arthroscopy and determine the influence factor for the survival rate. So between 2009 and July 2011, 38 patients with dysplasia who underwent arthroscopic procedure by single surgeon. 28 met inclusion criteria, minimum 2 years follow-up, mean age 28.4, the gender 6 male and 22 female. Surgical strategy is key is to recognize and treat accordingly, protect the capsule and labrum repairs, and do not debride the torn labrums, and no limb trimming, just tiny limb refreshes, and evaluating dynamic impingement and cam femoral osteoplasty was performed if applicable, and no capsulectomy and closed the capsule. So 26 of 28 patients combined with cam impingement underwent labrum repair and cam osteoplasties. The 2 remaining patients underwent labrum repair and without osteoplasties. So result, the overall evaluation was excellent in 22 patients, and the initial arthroscopy failed in 6 patients, 2 underwent THA, and 2 underwent RAO, and 2 underwent shell acetabuloplasties. So in 20 of 28 patients, modified healthy hip scores, non-arthritis hip score significantly improved from preoperatively to post-operatively. To determine what the predictor is, so we investigated these parameters: C angle, VCA angle, and the Shenton line broken, the BMI, the condylar damage, and the ROC curve analysis to assess the usefulness of preoperative factor as a predictor of post-operative status. This slide shows the distribution of VCA angle versus C angle. So triangle dot actually shows the failure clinical outcome of the patient. So ROC curve determines the cutoff value of VCA angle 13 degrees and C angle 17 degrees. The patient with less than VCA angle less than 13 degrees, only 46% of the survival rates. And the C angle less than 17 degrees, the patient have only 50% of the survival rate. So if the patient have with a broken Shenton line, only 40% of the survival rate. And if the patient have a severe condylar damage at limb region and femoral head, only 55% of the survival rate. So summary is the predictor of the poor clinical outcome of broken Shenton line, C angle less than 70 degrees and the VC angle 13 degrees and severe cartilage damage. But answer for weight with dysplasia is indication for only hip arthroscopic procedure for the dysplasia, mild dysplasias, no obesity, no broken central line, no severe instability, no osteoarthritis, severe contract damage, and no additional severe bone abnormalities such as paralysis and scurvy. So, however, the patient with borderline dysplasia really want to less invasive surgery if the patient participated in the athletic activities. So we devise new surgical techniques, fully arthroscopic approaches consisting of simultaneously treating the acetabular deformity and labrum tearings and cam lesion and capsular laxity, which is going to be published arthroscopic technique. Between 2011 and 2012, 32 patients were enrolled in these studies. 50 patients matched the inclusion criteria, 37.6 years old mean age. Case presentations, 70-year-old long distance runner with left hip pain for the past 6 months, limited range of motion of 100 degrees and positive impingement sign, and C angle less than 13 degrees and VC angle 18 degrees, suggesting anterior lateral uncovered socket. So we're going to show you the stepwise approach of endoscopic acetabuloplasties. So first we're going to do intra-articular procedures, intra-articular evaluation, and labrum suture fixation, and femoral osteoplasty if applicable, and capsule application. And switch scope to the extra-articular space. So we switch the scope extra-articular space under image intensifiers. And first we identify reflective head of the femoris along with the acetabular limb and debrided. And we introduce 2.4 mm guide wires along with the capsule and introduce the osteotome along with the guide wire to make the slot for the self-graft. The location of the slot is just from posterior 1 cm posterior from AIS, and we harvested the iliac bone graft from ipsilateral iliac crest and make the web-shaped self-graft and make the true drill force and for the guided to introduce the bone graft to press fit position by press fitting. Here you can see the post-operative X-ray shows the improvement of CE angle. So modified Harris hip score and non-arthritis hip score significantly improves at time of follow-up. So in conclusion, the predictor of poor clinical outcome following isolated hip arthroscopy for dysplasia, broken central line, CE angle less than 17 degrees, VGA angle less than 13 degrees, severe cartilage damage. This entirely arthroscopic approaches self-acetabuloplasty can be beneficial treatment for the patient with hip dysplasia. Thank you for your attention.
Very nice, thank you, Dr. Uchida. Next, we have Dr. Biljan from Turkey, who will be discussing the limits of saving hips.